It's because we had the concept for the trial at Cirque, together with Marie-Claude Maurice and Bernard Chevalier, and we talked to Biosensors. We were aware of their new product. We thought we knew how it would best be analyzed in the clinical practice. They liked it, and we went ahead. We're hoping to show that we can have the benefit of an active stent with the safety of a short DAPT associated with usually only bare metal stents. And we've gone from short to very long to lifelong and back to shorter. Certainly in Europe, there are a number of trials looking at this, and operators are more and more aware of the risk of bleeding associated with prolonged DAPT. So a device that could be shown to work with a short DAPT would be a major plus for the operators. We think that the device, because of the unique properties of the way it elutes the drug into the vessel wall, we think that it will be safe to use it with only 1 month's DAPT. If we can show that, and if it remains an active stent in terms of its limitation of TLR, then we're home. That's what we're hoping for. They are patients with a high bleeding risk. And because of that, when we look at them, we realize now that this actually describes a unique population. For instance, the mean age is in the range of 75 years old. It's 10 years older than the average all-comer trials. The use of anticoagulants is above a quarter of the patients. The renal insufficiency is present in more than 15% of patients. Cancer, 10%. They have severe comorbidity. They are different patients, and yet we all treat them every day in our cath labs. I think the efficacy will probably remain similar, and I don't see why the safety shouldn't be any different. So it will be up to each operator to decide how much he thinks that a DCS can replace a DES in his cath lab. I think it would replace a BMS in most instances, providing the results of our trial are those we hope they will be. And I think it will gradually replace DES for some selected patients. Whether it will entirely replace DES, and if so, in what sort of time frame, is another question. I think it's too early. We need more data, and then we'll see. Quite honestly, this one's an easy one. I see very few limitations. It's easy to use. It's a stent on a balloon. There's no reason operators would not go for it, and if the data's good, they'll love it. Short DAPT is possible, and we bring efficacy because it is an active stent, a DCS. But again, that short message will be contingent on the results of the trial.